Primary hyperaldosteronism. Primary hyperaldosteronism is an important treatable cause of hypertension in the young to middle-aged. Etiology. The majority of cases are due to benign aldosterone-producing adrenal adenomas, so-called Conn's syndrome. Other rarer causes are shown in Table 23. Epidemiology. Although primary hyperaldosteronism has traditionally been considered to account for less than 1% of all cases of hypertension, the prevalence of the condition is clearly dependent on the study population, with some authors reporting significantly higher rates, 2 to 12%, in selected patient groups. A slight female preponderance has been noted for adrenal adenomas. Clinical presentation. Most cases come to light during investigation of hypertension or unexplained hypokaliemia. Nonspecific symptoms including weakness, lassitude, and polyuria may be reported, reflecting potassium depletion. Physical signs. Mineralocorticoid excess per SE is not associated with specific physical signs. The degree of hypertension is variable, ranging from mild to severe, although malignant/accelerated hypertension is exceptionally rare. There may be associated signs of target organ damage, for example hypertensive retinopathy. Clinical evidence of edema is rare, except in those with concomitant cardiac disease. Investigation. Prior to investigation, ensure satisfactory dietary sodium intake, greater than 150 mol/day. Screening tests are traditionally performed having withdrawn agents, e.g. beta blockers, that interfere with the renin-angiotensin-aldosterone system. Alpha blockers, e.g. doxazosin, may be substituted if necessary. However, screening can be undertaken without changes in medication providing that certain precautions are taken when interpreting results. Screening tests. Urea and electrolytes. The classical picture is one of hypokaliemic alkalosis. The accompanying serum sodium level is usually normal to high. However, many patients subsequently diagnosed with primary hyperaldosteronism are normokaliemic at presentation. This is particularly likely to be the case if the patient is not on a potassium-losing diuretic and has a diet with a low sodium content, as urinary potassium excretion is related to the distal nephron sodium load. Urinary potassium and sodium. Hypokaliemia is associated with inappropriate kaliuresis. Urinary sodium estimation ensures satisfactory dietary intake. Plasma renin and aldosterone. The hallmark of primary hyperaldosteronism is the excessive autonomous production of aldosterone, which occurs in the face of renin suppression. The ratio of plasma aldosterone to plasma renin activity is a valid screening test for primary hyperaldosteronism and may be performed without changing antihypertensive medication. An elevated ratio is highly suggestive of the diagnosis. However, it is important to note that various factors can affect plasma renin activity and aldosterone, and hence the ratio. For example, renin secretion is stimulated by volume or salt depletion, e.g. as occurs with diuretic treatment, and is suppressed when beta-adrenergic input to the juxtaglomerular apparatus is attenuated, e.g. with beta blockade, or if the patient is treated with NSAIDs which promote salt and water retention. Hypokaliemia can impede aldosterone secretion and potassium. Supplements should be given to correct hypokaliemia before measuring aldosterone levels. Some laboratories now routinely measure plasma renin concentration or mass rather than activity, and it is important therefore to ensure that aldosterone and renin ratios are compared with the relevant reference range. Salt loading tests. In normal subjects, volume expansion due to salt and water retention will suppress plasma renin and aldosterone, whereas in primary hyperaldosteronism further volume expansion does not have the same suppressive effect on aldosterone secretion. Salt loading can be achieved by increasing dietary sodium intake, infusing saline, administering exogenous mineralocorticoid, e.g. fludrocortisone, or a combination of these, but should only be undertaken under specialist supervision, and not in patients prone to fluid overload, e.g. those with cardiac failure, renal impairment. Determining the cause. Plasma renin activity and aldosterone. Look for the following. Plasma renin. In normal subjects, adoption of an upright posture for 4 hours stimulates plasma renin when compared with resting supine levels. In patients with primary hyperaldosteronism, supine plasma renin is undetectable and remains suppressed despite ambulation. Aldosterone. Adrenal adenomas exhibit sensitivity to ACTH and, accordingly, aldosterone levels fall in parallel with the circadian cortisol rhythm. In contrast, idiopathic hyperaldosteronism is associated with a lack of ACTH sensitivity, with aldosterone levels typically increasing on ambulation. Aldosterone values must therefore be interpreted in the context of the serum cortisol. CT and MRI of adrenals. Both techniques can be used to identify the cause of primary hyperaldosteronism. Labeled cholesterol scanning and selective venous sampling. Radionuclide scanning and/or selective venous sampling may be helpful in localizing adenomas that have not been clearly visualized with CT/MRI. Treatment. Spironolactone is the medical treatment of choice because of its ability to block the action of aldosterone at the mineralocorticoid receptor. Treatment is titrated to normalize BP and restore normokalemia. Amiloride offers an alternative if spironolactone is poorly tolerated, and in some cases additional antihypertensive agents are required to control BP. Thereafter, specific therapy is directed at the underlying cause. Adrenal adenoma, unilateral adrenalectomy. Many centers now routinely offer laparoscopic surgery. Idiopathic hyperaldosteronism, long-term spironolactone or amiloride. Prognosis varies according to the underlying cause. For the majority of individuals in whom an adenoma can be identified, excision removes the source of aldosterone, but hypertensive end organ damage may be irreversible. Importantly, hypertension may not be cured by removal of the adenoma.